Hello everybody, my name is Eric Morgan, and today we're going to talk about an HIV and AIDS case study. I'm a senior nutrition major graduating this April. So a little bit about our patient. His name's Corey White, Caucasian, 24 years old, a high school football coach. He is homosexual and he was diagnosed with HIV last month due to unprotected male-to-male sexual contact. His HIV has not yet progressed to AIDS. It is still in the early stages right now. So a little anthropometrics of Corey White. He is 5'10", weighs 183 pounds. He has seen a 7-pound weight loss in the past 3 months. His blood pressure is in normal range. Total cholesterol looks good. His blood glucose is a little bit high. He is borderline of that pre-diabetic borderline range. So that is something to take into consideration. Typically with HIV patients, high blood glucose is a contradiction as well. His medical history, he has no alarming medical history pertaining to this disease. But currently, like I said, he has had weight loss in the past 3 months. It is not a significant amount, but he has definitely had some weight loss. He's had a chronic fever and persistent diarrhea too. His medications that the doctors are going to put him on are ART, that stands for antiretroviral therapy, and so with that you're going to get 2 dosages of an NRTI and 1 dosage of a PI. And the medications are azithromycin, didanosine, and apronavir. And the NRTI, that is a nucleoside reverse transcriptase inhibitor. So how that works is HIV cells will enter healthy human cells and they're going to try to replicate themselves, and they do this by reverse transcriptase. So this drug right here, they will block the active sites so that the HIV cells cannot do that. The PI, that is a protease inhibitor, and so that works by, protease is an HIV enzyme, and so then the PI will block the active sites from the HIV cells to lock on to the protease, which means that the cells cannot become mature and inactive. There are some medication effects with these 3 drugs that I have chosen. Zidovudine, taste alterations, loss of appetite, anemia, and vitamin and mineral deficiency. Didanosine, do not mix with acidic foods or antacids with magnesium or aluminum. Take on an empty stomach, and some side effects would be fat maldistribution, pancreatitis, loss of appetite, anemia, and also vitamin and mineral deficiency. Apronavir, take on an empty stomach, nausea, vomiting, diarrhea, hyperlipidemia, fat maldistribution, anemia, and liver toxicity. His lab values. So CD4 count, that is the major marker if HIV is present within the body. So CD4 count, that is the body's lymphocytes. It helps fight off infections. And so if that's low, you know that HIV is present, because that's what HIV does. It attacks these cells right here. And so below 500 is normally a pretty good indicator that HIV is symptomatic right now. And so he's at 400. TLC, total leukocyte count, in a normal person that is greater than 2,700, but with him it's below 1,000, so you can tell something's going on right there. Albumin levels, normal range is 3.5 to 5, and normally albumin levels are a little bit lower whenever someone's in great stress like he is right now. His nutrient intake and current activity. So this was just from one random day throughout the week during his teaching week. So for breakfast, he stopped at a convenience store, got biscuits and gravy and a 20-ounce Dr. Pepper. For lunch, he had a Tony's frozen pizza. And then for dinner, he had chocolate chip pancakes with a peanut butter spread and syrup all over them. Snacks throughout the day, he had an orange, trail mix, and a Hot Pocket. So based off this, the majority of his fruit is convenience food or frozen food or that's already pre-made. The only thing that he made himself was the chocolate chip pancakes, but that's not necessarily healthy or nutrient dense or anything. The snacks were not too bad. An orange and trail mix, that was a pretty good option, but the Hot Pocket, again, going back to him having a pre-made foods already there for him. His activity, he has practice every day for football and plays pickup basketball on the weekend. So he's more so he is physically active, but not necessarily exercising. And so I'm going to prescribe a little bit more exercise, and I'll talk about that here in some more slides. So M&T for our patient. So each nutritional plan for an HIV patient is to be modified for them. And this is the foremost goal, is to optimize nutritional status, immunity, and well-being of our patient. So typically you're going to see involuntary weight loss in an HIV patient, which, like we talked about, he has seen. And so I want to schedule a nutrition assessment every 2 to 6 times per year. And I just want to stress the importance to him of fluid sanitation and how to properly cook and handle food. I'm going to recommend small, frequent, nutrient-dense meals and suggest receiving all micronutrients from whole foods. But looking back at his diet, he's probably not receiving all his micronutrients from the whole foods. So again, I will just continue to take that multivitamin. Talking about his exercise prescription. So a person who is more physically fit is able to fight off infection a little bit better. And since HIV is limiting that, now he has to do everything he can to help fight off the infection. And so I'm going to prescribe 3 to 4 days a week where he is exercising. And with cardiorespiratory, 3 to 4 days a week, 15 to 30 minutes, RPE of 4 to 8. And with resistance training, 2 to 3 days a week, 30 minutes each session, and RPE of 4 to 8. And resistance training is definitely critical for an HIV patient because they are at risk for wasting. And so resistance training is going to keep up with his lean body mass and help preserve that. And those are my sources, and that is my case study.